Hello all, welcome back. We're continuing with the explanation series for MRCP Part 1 sample questions. Here is question 168. 55-year-old woman presented with 2-month history of lower back pain for which she had been taking paracetamol 4 gram daily. She admitted to drinking 16 units of alcohol per week. On examination, her BMI is 24. Investigation shown ALT is 55, AST is 29, ALP is 90. Serum IgG is 21, serum IgA is 2.4, serum IgM is 1.8. When you look, serum IgG is elevated. IgA and IgM are normal and she is having lower back pain. Lower back pain of a 2-month history with IgG elevated, and she is drinking alcohol, and others are irrelevant details. We'll look at what is the likely cause her for abdominal liver function test. Options are alcohol, autoimmune hepatitis, drug-related, gallstones, primary biliary cholangitis. So here AST, ALT and ALP were slightly elevated, and IgG is also elevated. So in autoimmune hepatitis, these antibodies can get elevated and also liver enzymes can get elevated. So it is autoimmune hepatitis. Okay, what about in primary biliary? Primary biliary, the antibody related to that is antimitochondrial antibody. Okay, so that is not the case here, and it's also a cholestasis kind of picture where ALP is highly elevated. Gallstones, drug-related, alcohol are all unlikely. So it is autoimmune hepatitis with the elevation of IgG. Next question. A 61-year-old man was referred for investigation of persistent, isolated, non-visible hematuria. So it's a elderly man, 61, with the non-visible hematuria. On examination, his BP was 121/76. Urine analysis showed blood 2+. Investigations showing HB16, white cell count is 12,500, creatinine 63, EGFR is more than 60, normal. Ultrasound scan of abdomen, 2 normal sized non-obstructed kidneys. What is the most appropriate next investigation? So it seems like that his kidneys are normal, right? Normal creatinine, normal GFR, and ultrasound is also showing normal, but he's having non-visible hematuria. And we are asked what is the next investigation. So here the patient is having hematuria with normal RF kidneys and GFR. So you have to rule out bladder cancer. Okay, so what is the investigation? ANCA, CT urography, cystoscopy, renal biopsy, serum Ig concentration. It is cystoscopy. Next question. A 58-year-old woman with autosomal dominant polycystic kidney disease presented with severe right-sided flank pain. On examination, she was in distress. Her temperature was 37.4 and the right kidney was palpable and tender. Urine analysis showed blood 1+, protein 1+. White cell count 8,200. What is the most likely reason for pain? So the patient is having ADPKD, autosomal dominant polycystic kidney disease, now coming with severe flank pain. Right kidney is also palpable and tender. Urine analysis showing also blood 1+. So what is the answer? There could be some hemorrhage in the cyst, right? Because white cell count is normal, so infection is unlikely. Cyst torsion and all happens in ovarian cyst, right? Not a renal calculus, not renal cell carcinoma, it's a cyst hemorrhage in a ADPKD. Next question. A 58-year-old man had a 3-day history of cough, breathlessness and fever. He had a history of ischemic heart disease and type 2 diabetes mellitus. On examination, he was slightly confused. His pulse was 105 beats per minute and his BP was 112/75 and his respiratory rate was 24 breaths per minute. Chest auscultation showed bronchial breathing at right base with coarse crackles. So let's decode the history. 3-day history of cough, breathlessness and fever. And he had ischemic heart disease and type 2 DM. Now the pulse is 105. He's slightly confused. Okay. BP is 112/75, respiratory rate is 24, and bronchial breathing at right pace. So it could be pneumonia with slight confusion and all. So you can calculate the curb 65 score, right? So here curb 65 score, what would it be? There is confusion, so that goes for 1. We look at the lab and see if urea is elevated. Respiratory rate is 24. Uh, what about BP? BP is also normal. So we have 1 score over here for the confusion, and age is also less than 65. So now he scored 1, and urea here you can see it is slightly elevated, more than 7. So that is also 1. So this is score of 2. White cell count is 18,000. Creatinine is 122. Plasma glucose is 12. And chest X-ray shows right lower resort consolidation. And the question is, what is the most appropriate initial course of action? Admit to high dependency unit, admit to medical ward, discharge with the course of oral antibiotics, monitor in intensive care unit, outpatient ambulatory management with intravenous antibiotics. So he can't be treated as an OP basis, right? Because there is curb 64. And now the patient is not in hypertension or in shock. So you can admit the patient, give IV antibiotics, and then later on, if worsen, you can shift out to high dependency or ICU. So it is admit to medical ward and give IV antibiotics. It is purely based on curb 65 score. There was one question on curb 65 score in this August exam also. They had asked what the kind of curb 65 score, something related to that was there. You have to know how do you calculate curb 65. Okay. Again, they asked what kind of a treatment choice would you use, IV antibiotics or oral antibiotics. Okay. Next question, a 52-year-old man presented to ED with shortness of breath and leg swelling. He had a history of hypertension, hyperlipidemia, and chronic alcohol misuse. Congestive heart failure was diagnosed and he was treated with furosemide, bisoprolol, and enalapril. On examination, GBP was elevated. There was a pan-systolic murmur with a third heart sound. ECG showing sinus rhythm at 60 beats per minute with left bundle branch block. Transthoracic echo shows left ventricular ejection fraction 25% with global hypokinesis. What is the most appropriate additional pharmacological treatment? So patient present to ED with shortness of breath and leg swelling. So likely that the patient is in heart failure. He had a history of hypertension, hyperlipidemia, and chronic alcohol misuse. Congestive heart failure was diagnosed. We are already given that the patient is in heart failure, treated with furosemide. So there is a diuretic, bisoprolol, there is a beta blocker, enalapril, there is a AZ inhibitor. But still, the patient has symptomatic heart failure. GVP is elevated. There is pansystolic murmur, third heart sound. Okay, and there is LBBB, and ejection fraction is also low with global hypokinesis. So what is the next line of pharmacological treatment? So already given AC inhibitor. Okay, the patient is receiving beta blocker and the patient is receiving a diuretic. What additional treatment will you give? Digoxin, eplerenone, hydralazine, isosorbide dinitrate, and ivabradine. It is eplerenone. It says potassium sparing. Again, diuretic that can be added along with your AC inhibitor, beta blocker, and furosemide if it is again symptomatic heart failure. Okay. Next question. A 42-year-old woman presented complaining of worms in the skin of her arms and legs for the past 9 months. She could feel the worms moving and had tried to get them out of her skin using a needle. She reported that the worms were gradually spreading and was afraid that would lead to her death. On examination, she was anxious. There were multiple needle marks on the skin of her arms and legs. Examination was otherwise normal. What is the most likely diagnosis? Options are delusional disorder, depressive psychosis, factitious disorder, generalized anxiety disorder, somatic symptom disorder. So when a question from psychiatry comes, I recommend that you read all the options, try and correlate and try and fix the answer and try to see if that is the correct answer. So the patient is having some worm-like feeling, and she's also trying to get it out of her body. And there are evidence of like needle marks on her arms and legs. So we look at the option delusional disorder. What is a delusion? Delusion is a strong false belief despite evidence to the contrary. So she has a strong belief that there are worms and she's trying to get it out of her body. So it could be a delusional disorder. What about others? Depressive psychosis means depression and psychosis like features. What is depression? Depression is low mood, lack of interest in activities that used to previously, find joy in. There is no history suggesting that. What about psychotic features? That means hallucination, delusion, and all. But here there is no evidence of depression and all. Factitious disorder means that the patient is believing that they are having a disease, maybe malingering, where they are trying to feign a disease for their own personal gain or benefit. Generalized anxiety disorder is when the patient is generally anxious about so many things, but here there is one strong false belief, so that could be delusion rather than generalized anxiety. Somatic symptom disorder means we can't find an organic cause for their symptoms, but they're having some kind of a somatic manifestations like mainly pain and all. Okay, so it is delusion disorder. Next question, a 32-year-old man with chronic hepatitis C virus infection is being treated with directly acting antiviral medication. What investigation is most appropriate for assessing his sustained response to treatment? So, hepatitis C, what is the investigation that can tell that the patient has responded to the treatment? Is it anti-hepatitis C antibody concentration, HCV viral load, liver biopsy, serum alanine aminotransferase, LD, serum CRP? It is HCV viral load that can indicate whether the patient has responded or not. Next question. A 67-year-old woman presented with palpitations and a goiter. Propranolol was started to improve her symptoms. On examination, she had coarse tremor and sweaty palms, but no thyroid eye signs. TSH less than 0.03, very low. Serum T4 25, slightly high. Technetium 99 scan of thyroid, increased uptake in right upper lobe with uptake suppressed in rest of thyroid gland. So there is an isolated thyroid nodule which is active and that is causing hyperthyroid with features. It's because she has tremor, sweaty palms, but no eye signs. So what is the most appropriate treatment? Carbimazole, prednisolone, propylthiouracil, radioiodine, total thyroidectomy. So for an isolated nodule, you go for radioiodine. Next question. A 68-year-old man was taking long-term warfarin for atrial fibrillation and his INR was stable at 2.8. What coagulation factor is most likely to be present at a reduced activity? So they're basically asking what is the mechanism of action of warfarin. So it is a vitamin K epoxide reductase inhibitor. And what are the vitamin K dependent clotting factors? It is 2, 7, 9 and 10. So you just have to look which is given in the option. There's 2, 7, 9, 10 which are vitamin K dependent. That will be affected. So among the option it is factor 7. And mechanism of action of warfarin is vitamin K epoxide reductase inhibitor. Okay. Next question. A 72-year-old man presented following a hematemesis. He had a history of alcohol-related liver cirrhosis. On examination, his pulse was 110 and BP was 90/60. HB is 10.4. What is the most appropriate first step in management? Patient had alcohol-related liver cirrhosis, now having hematemesis, and is in hypertension and there is anemia. What is the first appropriate management? Blood transfusion, intravenous albumin, intravenous gelatin, intravenous omeprazole, intravenous sodium chloride. So first you have to resuscitate, fluid resuscitation for the patient because the patient has low some blood and is in hypertension. So before your close matched blood comes, you have to give intravenous sodium chloride 0.9%, normal saline. Okay. Next question. A 57-year-old woman attended diabetes nephrology clinic for annual review. Her history included hypertension, type 2 DM, and diabetic retinopathy. An examination of BP was 168 over 98. Urine analysis showed protein 1 plus and glucose 1 plus. What is the most useful investigation to determine her future cardiovascular risk? So, the patient is having history of hypertension, type 2 DM, and diabetic retinopathy. Now come for annual review. BP is 168/98. There is protein 1 plus and glucose 1 plus. What is investigation which determine her future cardiovascular risk? 24-hour urine collection for protein estimation, urine lipid peroxide test, urine albumin creatinine ratio, urine microscopy, urine protein creatinine ratio. There is a protein leak that we are calculating, and one of the finest measurement for that is urine albumin creatinine ratio, not the total protein but albumin. So that is the answer, urine albumin creatinine ratio. That can also determine her future cardiovascular risk. And for these patients, dapagliflozin, which is an SGLT2 inhibitor, which is inhibiting the reabsorption of glucose at the kidney level, is being recommended for cardiovascular protective effect. So it is dapagliflozin for managing diabetes in a CKD patient. And the investigation that can determine the risk of development of cardiovascular diseases, urine ACR or albumin creatinine ratio. Next question. A 77-year-old woman presented with 1-day history of fever and tiredness. She had been discharged after surgery for a fractured neck of femur 1 week previously. She had received 2-unit red cell transfusion before discharge. She was taking nitrofurantoin for a urinary tract infection and rivaroxaban as thromboprophylaxis. Investigations before the transfusion, HB was 78 gram per liter, and now it is 76 with MCV high. White cell count 10,800, platelet is okay, 2.07. Reticulocyte count is 146. That is also high. That indicates hemolysis. Okay, high reticulocyte with low HB after a transfusion, which was 1 week before. And direct antiglobulin test or Coombs test is positive, which indicates hemolytic hemolysis or antibody-mediated hemolysis. What is the most likely cause of her anemia? Autoimmune hemolytic anemia, bleeding, delayed hemolytic transfusion reaction, drug-induced hemolytic urinary tract infection. She was taking nitrofurantoin and rivaroxaban. So here in this case, she was also received previous transfusion and now presented with hemolysis, which is antibody-mediated. It is likely to be delayed hemolytic transfusion reaction. Okay. Next question. A 75-year-old man was admitted with a 10-day history of generalized reddening of skin accompanied by shivering and thirst. He had a history of psoriasis. On examination, his pulse was 110, BP was 110/60, and he had dependent edema. His skin was uniformly erythematous and scaly. What is the most appropriate initial treatment? So, patient had a history of psoriasis. Now come with generalized reddening of skin, and his vitals are stable. His pulse is slightly high. He had dependent edema also. Skin is uniformly erythematous and scaly. So what do you give for that patient? We can give some topical treatment, and that is topical white soft paraffin. Next question. A 24-year-old woman presented with shortness of breath at sudden onset. She had been at a nightclub and had been drinking wine but denied taking any illicit substance. She had no relevant medical history. She was a non-smoker. On examination, temperature was 37, pulse was 100 and BP was 110/70. Respiratory rate was 32 and oxygen was 98%. So vitals stable, some tachypnea is there, and she was in a nightclub. And she's just 24 years old with no previous medical history and a non-smoker. ABG showed PO2 is okay, normal. PCO2 is low. And with tachypnea, that indicates hyperventilation. pH is high, again goes with hyperventilation. H plus 36, bicarbonate is 19, that could be just low due to compensation. Base excess is -2. Chest X-ray is normal. What is the most likely diagnosis? So it is hyperventilation, maybe due to that anxious situation or the loud sound and all. Some people may experience, a stress that can precipitate hyperventilation, and the saturation ABG only there will be hypocapnia. Carbon dioxide will be low because there is increased carbon dioxide washout, and there can be alkalosis, but PO2 and saturation all will be normal. It can be tachypnea also, but chest X-ray will be normal. Next question. A 30-year-old man with Marfan syndrome presented with sudden onset interscapular pain. So in Marfan, what is the most likely cardiac abnormality? It is aortic root dilatation. That is one of the favorite questions. Aortic root dilatation. That is complicated now to become aortic dissection in this patient. Which protein is most abnormal in this syndrome? A direct question. Which protein is abnormal in Marfan? It is fibrillin. Okay. Next question. A 70-year-old man presented with acute abdominal pain. At laparotomy, his bowel was found to be ischemic from lower part of duodenum through midway along the transverse colon. So, from lower part of duodenum, then comes your jejunum, and then comes your ileum, and then that connects to your colon. There is your ascending colon, and there is your transverse colon. So here ischemic from the lower part of duodenum all the way through till the ascending and midway along the transverse. We are asked which artery is most likely to be occluded. So the stomach and first part of duodenum and all is supplied by the celiac trunk. Then the rest until the transverse is supplied by the superior mesenteric. Then the descending colon, sigmoid, rectum, everything is supplied by the inferior mesenteric. So here it is the territory of superior mesenteric. Because all of this is affected. Middle colic is all is a branch of that, but that won't involve all of this. Ileocolic again is a branch that won't involve all of this. Celiac is supplying stomach and first part of duodenum. Inferior mesenteric is supplying descending colon and sigmoid and rectum. So it is superior mesenteric artery. Next question. A 21-year-old man presented to an emergency department after he had vomited a small amount of blood earlier that day following an episode of severe retching. He was otherwise well and was not taking any medication. So there is history of severe retching and there is some hematemesis. Vomited small amount of blood. Pulse was 95, BP 115/85, vitals are stable, HB is 133, again no fall in HB. Prothrombin time 12, normal, urea 5.2, there is no dehydration. Serum GGT is 25, so not likely to be a hepatic problem, and just 21 years old. What is the most appropriate next step in management? Options: admit for 24-hour observation, admit for urgent upper GI endoscopy, discharge with reassurance, refer for outpatient upper GI endoscopy, refer for outpatient Helicobacter pylori breath test. So there was history of severe retching. So it is more likely to be Mallory West there. You can just reassure the patient, tell them that it is due to severe retching. Other labs are normal, there is no anemia, vitals is stable, so they can be sent home. Discharge with reassurance. Next question. A 30-year-old man with type 1 DM presented on onychomycosis affecting 4 digits of his left foot. This had been unresponsive to 6-month course of topical lamorolfin. Nail culture showed trichophyton rubrum. What is the most appropriate next treatment? So again, with the nice guidelines, after topical lamorolfin, what will you give? We go for some oral treatment, and the recommendations say oral terbinafine as the next line management. Next question. A 33-year-old man presented with dyspepsia and on serological testing was found to have H. pylori infection. With which condition is H. pylori infection most strongly associated? So you have to stress on this, most strongly associated, because H. pylori is associated with many of the things given in the options. H. pylori can be associated with duodenal ulcer, gastric carcinoma, gastric ulcer. GRD does not have much association with H. pylori, non-ulcer dyspepsia. So what is the most common association? It is duodenal ulcer. Next question, a 43-year-old man who had recently immigrated from Bangladesh presented a 3-month history of breathlessness and productive cough, which had markedly worsened over the past week. On examination, his pulse was 105 and his BP was 95/54, JVP was 6 cm above the sternal angle. Coarse crackles were heard in the right upper zone. Echo showed 5 cm pericardial effusion with diastolic collapse of right atrium and right ventricle. What is the most likely abnormality found in pulse? So they are asking, with pericardial effusion, what kind of a pulse do you expect? So with pericardial effusion, you see pulses, paradoxes. So actually it is a misnomer because there is nothing paradoxical. It is actually exaggeration of the normal response. So with inspiration, what happens? There is increase in intrathoracic pressure, okay, and there is reduction in the end diastolic volume, and that is why there is a fall in BP, because stroke volume reduces and systolic BP is depending on the stroke volume. So there is a fall in SPP with inspiration. With pulse pericardial effusion, there is major reduction in this in diastolic volume. So this fall is exaggerated. So there is fall in SBP, systolic blood pressure, more than 10 mmHg. That is what is called pulses paradoxes. It is not paradoxical, actually it is exaggeration of the normal response seen with pericardial effusion or seen in also severe asthma and cardiac tamponade, etc. So we'll see what are the other options. Here the answer is pulses paradoxes. What are other options? Anacrotic pulse. What is anacrotic pulse? It's low amplitude, slow rise, late peak. So what is your normal pulse look like? There is a systolic peak and then there is a diastolic wave. From there, actually there is also a dicrotic notch. What happens in anacrotic? This amplitude, that systolic amplitude will be reduced. Also, only there is a slow rise, okay, and the peaking is also late, okay. It's called pulses parvus et tardis. Parvus means low, and it is et tardis. It is seen in aortic stenosis. That is your anacrotic pulse. What is collapsing pulse? A rapid rise and a rapid fall, seen with aortic incompetence, can be seen in high output states like anemia and also in AV fistula. What about pulses alternance? It's alternating in volume. High volume followed by a low volume, then again a high volume followed by a low volume. Okay. What about bispherians? Bispherians is here you have a single systolic peak. Bispherians means you will have a double peak in the systole itself. Not the dicrotic notch, but the systole itself will have a double peak. That can be seen again in aortic regurgitation. And your bigeminy is alternating in character of the pulse, high versus low. This is alternating in volume. Alternance is alternating in volume. So those are the pulses. So with pericardial effusion, you see pulses paradoxes also seen in severe asthma. Next question. A 75-year-old woman presented following an impulsive overdose of 3 times her normal daily dose of warfarin. Her husband had died 4 years previously. She did not normally drink much alcohol but had consumed 6 units of on the day of overdose. What is the most predictive of completed suicide next week? So we are being asked what increases risk of suicide. So male sex can increase suicidal risk. Alcohol abuse can increase, but she normally does not drink much alcohol. Then previous attempts or that can be a risk factor. Then age. Here the age is high, right? 75. So that can be a risk factor. So age over 70 is the risk factor here. Male sex is more common than the female. Next question, a 55-year-old man presented after recent MI. He was concerned about the risk about two other family members after reading a newspaper article about association studies that mentioned ischemic heart disease and single nucleotide polymorphism genotyping. What is most appropriate definition of SNP? A direct question. What is single nucleotide polymorphism? The options are alteration in nucleotide sequence that causes a change in amino acid sequence. Alteration in nucleotide sequence that does not cause a change in amino acid sequence. Deletion of a single nucleotide, repetition of a nucleotide two or more times, substitution of a nucleotide for any other nucleotide. So single nucleotide polymorphism means substitution of a nucleotide for any other nucleotide. Next question. An 83-year-old man presented with 6-month history of pain in both legs on walking, which was relieved by short periods of rest, particularly sitting down. So a claudication-like pain, okay? He had a past history of myocardial infarction. On examination, his foot pulses were present. So there is no actual claudication. There is no arterial insufficiency. But a claudication-like pain is there because there is pain in walking relieved by rest. There was crepitus in both knees and both angle tendon reflexes were absent. Seems like a neuronal issue, right? What is the most likely cause? OA knee. OA knee will have crepitus in knee but will not have change in reflexes. Peripheral arterial diseases? No, because foot pulses are present. Peripheral polyneuropathy, in polyneuropathy you don't get crepitus in knee and all. Again, tendon reflexes will not be affected. Spinal stenosis. It can mimic arterial claudication pain. So that is the answer. Not venous insufficiency because there is no venous ulcer, there is no venous engorgement. So here it's spinal stenosis because it can mimic claudication pain. So remember, spinal stenosis can mimic claudication pain. Next question. A 24-year-old man presented with 2-week history of leg swelling. He had experienced an upper respiratory tract infection 1 month previously but had not required antibiotic therapy. He had no significant medical history. Maternal uncle had undergone a successful kidney transplant. On examination, there was peripheral edema to thighs bilaterally. Urine showed 1 plus blood and protein 4 plus. Urea is 6.6, creatinine is 102, GFR more than 60, albumin is 22. What is most likely diagnosis? So the patient is young, 2-week history of leg swelling is there, and there was an upper respiratory tract infection 1 month previously, but not required any antibiotic. No significant medical history also. Urine analysis showing 1 plus blood and protein 4 plus, majorly nephrotic like picture, but GFR is preserved, creatinine is not that elevated, and there is albumin is lowest. Options are Alport syndrome. With Alport, you usually have a hearing loss syndrome. Autosomal dominant polycystic kidney disease, not mentioned, and also it presents later on in life. IgA nephropathy, not this kind of a picture, right? There will be some mention of an IgA thing and all. Membranoproliferative glomerulonephritis or minimal change disease. Here there is no major rise in creatinine and all, so it is minimal change disease. In minimal change disease, only in renal biopsy you see only podocyte. Podocyte means food processes. Effacement of podocyte. Podocyte will be lost. That is the only change that you can see, not in normal microscopy but electron microscopy. That's minimal change. Next question, a 42-year-old woman was referred following a health check. She was asymptomatic but had been found to have hyponatremia. She had a history of gastroesophageal reflux treated with omeprazole. On examination, she had no postural drop in BP. So the patient had hyponatremia. She was taking omeprazole. Sodium is 131. Okay, potassium is 4.5 normal, creatinine is 88 normal, random plasma glucose normal 4.6, serum osmolality is 271, slightly low, urine osmolality is 735. In the normal range. Urinary sodium is 36. and serum cortisol is 524. What additional information would be most useful to support a diagnosis of SIADH? So, syndrome of inappropriate ADH secretion. So, there is increased loss of sodium in the urine. Okay, there is increased secretion of ADH also. Others are normal, cortisol is normal, and there was urinary sodium was high. So what is the next information that you need to support SIADH? Daily fluid intake, daily urine output, no further information needed. Serum cholesterol level, thyroid function test. You may think that you need not need any other information to diagnose SIADH because urinary sodium is high, sodium is low, serum sodium is low. Okay, and serum osmolality, urine osmolality, you get a picture because serum osmolality is low and urine osmolality is on the higher side. So what else do you need? You actually have to rule out something else. So you have to rule out hypothyroidism. Thyroid function test should be done before you go in and comment SIADH. So TFT should be done. Next question. A 19-year-old man presented with 6-month history of increasing social withdrawal, having become convinced that he could hear his innermost thoughts being spoken by people whose voices he did not recognize. So there is somebody is speaking to him. Right? He spent hours pacing about in his room. Substance misuse was excluded and a diagnosis of schizophrenia was made. He was treated with risperidone, which receptor is chiefly involved in mediating antipsychotic effects of risperidone. A very direct pharmacological question. Risperidone, effector, dopamine receptor. Okay, so D2. Next question. A 68-year-old man was advised to take isosorbide mononitrate 30 mg twice daily for angina pectoris. What is the most important mechanism of action of this drug? Isosorbide mononitrate. Again, from pharmacology. It is increased cGMP production or increased cyclic guanosine monophosphate production. Okay, calcium channel blockade, sodium channel blockade and all comes under anti-arrhythmic. Sodium channel blockade is class 1. Okay. So this increased cGMP production. Next question. A 68-year-old woman with AF presented for DC cardioversion. The procedure resulted in successful restoration of sinus rhythm. What drug most likely to maintain sinus rhythm following procedure? Options are amiodarone, digoxin, diltiazem, sotalol, verapamil. So you give amiodarone, right? Amiodarone is the drug of choice following DC cardioversion in a patient with AF. Next question. A 30-year-old man presented with 2-year history of intermittent facial rash. On examination, there was an erythematous scaly rash involving nasolabial folds and eyebrows and skin overlying the sternum. There was mild scaling of scalp and the nails were normal. What is the most likely diagnosis? So 2-year history of intermittent facial rash. And there is erythematous scaly rash involving nasolabial fold, eyebrow, skin overlying the sternum. Mild scaling of the scalp also. So most likely, seborrheic areas, right? And nails are normal, so against psoriatic. So psoriasis is gone because nails are normal. Eczema, atopic. Options are atopic eczema, contact dermatitis. So this is in seborrheic areas, so you suspect seborrheic dermatitis. Next question. A 79-year-old man with renal cell carcinoma with metastasis involving his lungs and liver was treated with morphine sulfate for pain control and clarithromycin for respiratory infection. Investigation showed urea 18, creat 200. So it is high. Again, urea is high. Albumin is 28, low. Total bilirubin is 20. So he is having renal cell carcinoma with metastasis. Bilirubin is 20, ALT is 300, ALP is 1050. That is also high because he has lungs, liver metastasis and renal cell carcinoma. That's why the lab investigation is like that. Question is, what is most likely to cause morphine toxicity? So morphine causes toxicity in a patient with renal impairment. That's why we use fentanyl in such patients. So the answer is renal impairment. So that's all for today. We have completed the complete series of sample questions in the RCP website, but we have more things coming up related to MRCP part 1. So thank you. Follow for more updates on MRCP. Thank you for joining the channel.